I understand that others have also had the experience of getting treatment for this vaccine. Please, can you tell us about that?
Yes. First, we had many patients when we still had access to the vaccine, and we had about 250 patients who kept on taking it. But 205, when it was withdrawn, they had to stop. But still, I have a few more close friends, and especially one in Stockholm whose name is Lars Lagerstrand, who is an assistant professor at the Karolinska. He is very fond of this treatment and has been taking it for now at least 20 years. And indeed, he appreciates it very much because he can still work. Yeah, but it is very frustrating not to be able to treat any new patients, of course.
And there are some mechanisms.
Yeah, we had some cooperations with a professor in physiology, in immunology at the Karolinska Hospital, whose name is Roland Mölndal, and he measured the titers of antibodies in our patients, and he could show that the concentration of antibodies against some toxins from the Staphylococcus could be significantly correlated to the clinical effect, which we evaluated with some rating scales. So it points to some sort of working mechanism in the project, yes.
So you think it's some kind of infection that triggers the immune system to get started?
Yes, and there we have problems, because you could either think in this way that there is a continuous infection who keeps on triggering the infection and then triggers the fatigueness patients suffer from. But you can also assume that these infections starts an autoimmune process. So the infection is no longer there, but there is an autoimmune process who attacks other parts of the body or some parts of the body. And yeah, we have some data about this, which we perhaps will come to later on, yes.
So, and then you in this clinic, you started this clinic and you had to change a little the way of research and the way of treatment or diagnostics and so on.
Yes, we really have to change track here because we had hoped to be able to treat a lot of patients but couldn't do it. But then we noticed that the patients really appreciated to come here and to get information about their disorders. And then these patients also have other kind of symptoms. They can get a little depressed, they can have some pain in the body and sleep disturbances. And they need help with these symptoms too, and we can help them with some pharmacological drugs, and they appreciate that very much. Because I must say one thing, and that is the knowledge about these disorders. In primary care, the knowledge about these disorders is not very great, and these patients have great difficulties to get an understanding about their disorders, and therefore they appreciate very much to come here.
I understand that you use some kind of diagnostic instruments in order to see what kind of illness they had. Please tell us about that.
Yeah, in fact, we don't have any instruments really to make the diagnosis. So the diagnosis is a criteria diagnosis. That means that you have to know the symptomatology of these disorders very good and ask the correct questions to the patients. And then you can record whether they really fulfill the criteria for the diagnosis. The diagnostic criteria we use is the Fukuda et al. Publication, where the first criteria was described. I think it was in 1992. Later on, more strict criteria has been presented, named the Canada criteria. And now we use that in research. We also use the international consensus criteria sometimes. This means that you today know this disorder rather well and can delimit it rather good. Especially in research, of course, is that important.
But isn't it also so that you have to make a medical examination to exclude other diseases?
Correctly. That we have to do. And we have to do laboratory investigations really to exclude other infection disorders like borreliosis and similar infections. And also, of course, other explanations. There, perhaps I should say that we are very interested in studying treatment of these patients with vitamin B12 and folic acid, because, and that's a piece of knowledge we have with us since I was interested in dementia and aging, where we had noticed also that the deficiency of vitamin B12 could be of importance. And we have noticed now that also chronic fatigue patients who very often complain of a brain fog, that these patients say if they get high doses of vitamin B12 in injections every week, they say that this brain fog disappears. And they appreciate that so much that we have had to continue that treatment. And at present we are trying to make research of this too, to see whether there is any disturbance of the transport of the vitamins B12 and folic acid. And it could be so that the transport from the blood into the brain is disturbed.
But is that in combination with folic acid, or?
It's in combination, yes. We always combine vitamin B12 and folic acid because these two vitamins take part in a very important metabolic process, which is usually named the one-carbon metabolism. Some patients may even have a genetic, not a genetic defect, but a genetic uniqueness where they have a weakness for needing more folic acid than normal.
So it could be a genetic disposition with some that needs these extra vitamins.
It is not a genetic disposition. It might be so, but this vitamin defect doesn't explain the disorder, but it could explain some of the symptoms. And you get a symptom relief if you substitute them with a rather high doses of these two B vitamins.
And I understand that you have now in the process of starting a study together with Open Medicine Institute in California, is it?
Yes, that's right. There is an interest also in the US about giving these patients vitamin B12. And we are now planning a study where we shall treat them with B12 plus folic acid in a double-blind methodology to see if we can prove that this is true, that the brain fog disappears when you substitute them with these vitamins.